Hello and welcome back. I hope you were all able to enjoy a very nice lunch. I'm Laura Russell, one of the clinical social workers on the brain health team with AdventHealth. You will now be hearing from our neuromuscular medical director. Immediately following Dr. Jarrett's talk, please stay tuned for a special presentation by our very own AdventHealth Music Therapy Program. It is my pleasure to introduce our neuromuscular medical director, Dr. Navita Jarrett. Dr. Jarrett was blessed to graduate from Harvard University, where she was an award-winning student and athlete. She earned her medical degree at the Mayo Clinic, College of Medicine, and returned to Harvard for her neurology residency. She followed her husband to Iowa City, where she completed consecutive fellowships in neurophysiology and neuromuscular diseases, and earned a master's degree in translational biomedicine at the University of Iowa. Before moving to Central Florida to serve as the Neuromuscular Division Director, Dr. Jarrett served as the Director of the Charcot-Marie Association Center of Excellence and as a Clinical Assistant Professor at the University of Florida. Currently, she leads the Neuromuscular Program at AdventHealth. Dr. Jarrett is board certified in neurology, neuromuscular medicine, and electrodiagnostic medicine. The program holds 2 centers of excellence with the Hereditary Neuropathy Foundation and the Periodic Paralysis Association, as well as being an ALS-affiliated clinic, National NDA Care Center, and a partner in care for Myasthenia Gravis Foundation of America. The clinic is accredited as an EMG lab with exemplary status. Dr. Jarrett is also a member of the Periodic Association Board of Directors. We hope you enjoy Dr. Jarrett's talk on neuromuscular medicine.
All right, so I'm very excited and honored to be here today to talk for the Brain Health Conference. And just as a background, I'm the Neuromuscular Director at AdventHealth. My name is Dr. Jarrett. Here's some of my contact information, and I'm really excited to be here because this is just a great beginning to our Neuroscience Institute, and it's so well organized. This whole entire conference, I was asked to speak, more than a year ago. The planning had started for this conference. So let's get started and talk a little bit about neuromuscular medicine. So everybody comes into my clinic, a lot of people do, and they ask, what is neuromuscular medicine? I have patients that tell me, that they can't pick up a spoon or they can't walk. And a lot of times it's because they're unable to do it. They have a tremor. The tremors are not neuromuscular medicine. Neuromuscular medicine, when I see a patient that is affected, it usually involves 2 major components of the neuromuscular system. That involves strength and sensation that's a big picture concept, both strength and sensation. So losing strength is weakness. And when my patients have weakness, they're just not able to do the things they used to do. And I'm not sure if you're ever familiar with people or seen people who are just walking slower than you are, and they're just not able to pick up their feet, or they're unable to climb stairs, or they're unable to talk. Some of them are unable to eat or swallow, or even pick up a spoon or fork. Sometimes they're not able to cut vegetables. Sometimes they can't run. Some of my patients have very tough complaints. They're hard to figure out what they're really saying. But sometimes they say that, look, they can't get up on a horse, or they can't squat down or get up from a chair. Things like that. That involves weakness and involves strength in the body. The other component to neuromuscular medicine is sensation. So some people say they have tingling or numbness, they can't feel their feet, they have problems with balance. So the neuromuscular medicine, really the big picture is that they just don't have the strength they used to, and they don't have the sensation. And because of that, it can come and manifest in so many different ways, whether it's walking or talking or eating and doing things that we take for granted. Now, the key for this slide, you'll see this transition slide whenever I transition to different parts of the neuromuscular system. But neuromuscular disorders are outside of the brain, inside the spinal cord. So the central nervous system involves the brain and the spinal cord. But the neuromuscular medicine's everything outside of that. And that includes the motor nerves that go to the muscles, the sensory nerves that go to the skin, And then once the motor nerves go to the muscle, they connect to the muscle at the neuromuscular junction. And then once they connect to the muscle, and that's the muscle. So there can be disorders anywhere along these pathways outside of the brain and spinal cord. So the first part that we're going to talk about are the motor nerves. The motor nerves, they're very important, and we take them for granted. They actually carry signals from the central nervous system all the way to the muscle to perform a certain movement. And some of the common motor nerve disorders that we see in our clinic include ALS, amyotrophic lateral sclerosis, and SMA, or spinal muscular atrophy. So these are disorders of the motor nerves. ALS, or Lou Gehrig's disease, I don't know if some of you know what this disease is. It was named after Lou Gehrig, who was a famous baseball player. And the problem with this disease is this progressive motor nerve degeneration. It causes wasting of muscles, weakness, fasciculations, which is, these are where the muscles are twitching on their own, and that's called fasciculations. As a result of the motor nerves degenerating, people are unable to move, and they're eventually paralyzed. And unfortunately, many of them do not survive. They die within about 2 to 3 years of the diagnosis. I don't give anybody a strict timeline because we really don't know, when that can happen. But it's a very devastating disease, and even more devastating because we don't have any treatments. In our clinic, we hope to start a clinical trial soon, and we do put patients on medications to help prolong their survival a little, as well as make them comfortable. But it's a really devastating disease where the motor nerves degenerate, and eventually patients will die. Spinal muscular atrophy is another disease of the motor neuron, but it's genetically inherited. So most of these patients have a genetic mutation that causes disease. A lot of times the kids can be born with it, and it can be seen at a very early age. The later the age of onset, the milder the disease. And so we have patients who have more symptoms when they're in their teens than when they're kids, and they're just a little bit milder. The great news about this disease is that we do have treatment options for those that are caused by the mutations in the SMN gene. So it's a great victory for the neuromuscular medicine field that we were able to get treatments for SMA. We have now, going back to our slide, we went to the motor nerves, and we're going to switch over to motor and sensory nerves. And when we have a combination, this is what makes neuromuscular medicine difficult, is that the next part is peripheral neuropathy. And peripheral neuropathy can involve motor nerves, sensory nerves, both, or either motor or sensory. So neuropathies, that's what I just said, both involve and can involve either one, motor or sensory, and they're length dependent. So typically neuropathies involve the hands and the feet. Some patients may have a neuropathy that involves more motor involvement, which is weakness, and some might have more sensory involvement, which is more numbness or pain. And what's important about those sensory nerves, which we really haven't talked about, is that they can manifest in different ways of problems. Some people can have problems with pain in their feet. Some people can have problems with balance. Some people can't feel temperature, and some combination of those. And as you can see, this is a slide. Typically, the neuropathies affect the feet and the hands. So they're length dependent. The nerves travel all the way from the spinal cord all the way to the hands and down to the feet. Okay, so a lot of variety, a lot of difficulty in diagnoses, a lot of variability in neuropathies, but we will go over the different ones that we see in our clinic and the common ones we see in our clinic. So the three common ones I wanted to present today were Guillain-Barré syndrome, or CIDP, chronic inflammatory demyelinating polyneuropathy, diabetic neuropathy, or Charcot-Marie-Tooth disease. So Guillain-Barré syndrome, I have a lot of patients that have GBS or CIDP, and the key distinguishing feature is the time. So your classic patient, this is very classic, this is the most typical, not the atypical, but the very typical patient with GBS. This is someone who comes in, they had a stomach illness, they ate something, they've had diarrhea, and they wake up in the morning, and the next thing they know, they can't really move their feet. They may have some numbness or pain. They may have weakness in their hands, and suddenly it's getting worse very quickly. So they run to the ER, they get tests done, and they get treated usually with immunotherapy. And once they're treated, within about 2 to 3 weeks, they get improvement. And then by 4 weeks, they're usually better, up to a point where there are no deficits for most cases with Guillain-Barré. They might have a little bit of numbness left, but for the most part, they're just back to baseline. But the distinguishing feature between Guillain-Barré and CIDP is that CIDP is more than 4 weeks. So if patients do not get better, if patients have a longer course of their sickness, then they fall into the category of CIDP, where treatment needs to last longer. And the reason why I really emphasize that is because I see patients in clinic who have been diagnosed with Guillain-Barré, but they're not better fully, and they need more treatment. So it's important that if patients are struggling, if you're struggling with this, or if you know someone who's struggling with this, it's important to get continued care and treatment, because with treatment, patients can get a lot better. The other common neuropathy we see is diabetic neuropathy, and I tell all my patients that the sugars, the high blood sugars or fluctuations in blood sugars from diabetes can actually reduce blood flow to the nerves. And this causes very commonly pain in the feet, sensory loss, and sometimes weakness. We have a diabetic neuropathy clinic that we offer with AdventHealth, so it's something that really helps patients. Another form of neuropathy that we see, because our clinic is a center of excellence in hereditary neuropathies, is Charcot-Marie-Tooth disease. And this is a hereditary neuropathy. A lot of people are born with this condition. They have very commonly high arches and hammer toes. They will over time have weakness in their hands here and their feet. And they usually have a family history, typically. Sometimes they don't, and we do a lot of genetic testing. We try to help patients that have this and help treat them. As I said, we are a center of excellence, and we have a very successful CMT1A clinical trial. So that's another neuropathy that we see. So moving outside from the nerves and going right next to the anatomy, from the nerve to the muscle, is the neuromuscular junction. And this is a really fascinating anatomical part of the peripheral nervous system. This is an area where the nerve connects to the muscle and communicates to the muscle with a neurotransmitter called acetylcholine. And what's really interesting about the neuromuscular junction is that this transmission is done by this neurotransmitter called acetylcholine, and there can be diseases where that transmission is impaired. And the most common disease that we look at is called myasthenia gravis. And with myasthenia gravis, the nerve is trying to talk to the muscle, but unfortunately there are antibodies that develop and don't allow that acetylcholine to go to where it should. And the nerve cannot communicate with the muscle as easily. And because of this, patients get what we have, double vision, they get droopy eyelids, as you can see here in this picture. Some people have worsening weakness. They're not able to walk. They'll walk, be very, very strong in the morning, but at the end of the day, they'll have to lie down. Sometimes after a few hours or even half an hour of activity, depends on how severe their condition is, they will need to lie down. One of my patients said just driving his daughter to work, and right when he came back, he had to sleep and lie down because he was so tired. Going out to get groceries. Right after that, they feel like they have to take a break and rest, and that rest helps them recover. So fatigue, exertion, and heat can make this weakness worse. And it's an autoimmune condition. I mean, it's a condition that's like things like rheumatoid arthritis, has antibodies. And because of that, there are treatments. And we're very blessed to have a very big clinic. We treat a lot of patients, and a lot of patients get better. So, although it's a disease that can be very, very difficult to diagnose, but it's also something that patients have to struggle with in terms of fatigue and quality of life. We do have treatments for it, which makes it very satisfying. Our next the next condition outside of the brain and spinal cord, so another part of our peripheral nervous system. So we talked about the motor and sensory nerves, we talked about the neuromuscular junction, and last but not least is our muscle. So everybody knows when we say make a muscle, that means that's the muscles in our body. And it's the primary source of power in the body. It carries out a specific task. Now, this is by no means a comprehensive list of all the muscle disorders. There's so many out there. But I picked a few that we commonly see in our clinic. One is polymyositis. Another one are the congenital myopathies that people are born with. And another one are the ion channel disorders. So polymyositis involves kind of inflammation of the muscles that causes muscle weakness and pain, and there's so many different kinds. There's inclusion body myositis, there's dermatomyositis, among many others. But the good news is we see patients like this in clinic, and it's also autoimmune, and we can treat it with immunotherapy. And so you can see where the muscles are affected in the patient's body, usually in the shoulders and in the proximal leg muscles and the thighs, but not necessarily everyone's textbook. Regardless, we still treat them, and patients do pretty well with treatment. Our next type of muscle disease that we see in our clinic are muscle diseases that appear at birth or childhood, or people are born with it. Sometimes you can someone can be born with it, but they appear late onset. So an example is what we call Duchenne muscular dystrophy. Kids are born with this, and it's usually seen in young boys. They're unable to walk like the other kids, or run, skip like other kids. And we offer genetic testing for specific genetic mutations. There are treatments out there for Duchenne muscular dystrophy. We also offer muscle biopsies to help. Pompe's disease is another disease we see in our clinic very frequently, and this disease has treatment options. So I really like to make sure that we look out for this one. And sometimes Pompe's disease can show up later in life, in adulthood. Another disease are the ion channels. So this is inside the muscles, and they're really hard to see. But in order for a muscle to contract, there are different channels: the sodium ion channel, chloride, potassium, and calcium channels. They can lead, if they're mutated, they can lead to different forms of, whether it's paralysis or myotonia or other disorders. But typically, some patients, with a sodium channel mutation can have, episodes of paralysis, and that's called a periodic paralysis. We have a lot of patients we treat and help with conditions like that. So in our clinic, for those that have never seen the details, but they've read about it, I'm sure all my patients are sitting there, they Google EMG, nerve conduction studies, and that's an important diagnostic tool. It sounds very scary, but we try to make it as gentle as possible. The EMG, I always like to say this is similar to a microphone or a device that helps us listen inside the muscle, and we listen to hear any abnormal sounds, to see if the muscle is acting the way it should. Nerve conduction studies, those are studies that involve you see this little probe here, it gives a little bit of a shock to the nerve. And then we record the signals out here, and we actually evaluate if the nerve is traveling at the speed it should, if the nerve is responding the way it should, and we, determine whether it's functioning okay. So it may feel like you can read about this all day and say these tests are scary. We try to be as gentle as possible, and people get through it pretty much just fine. Our next thing we do very commonly in our clinic includes genetic testing. And this involves a saliva sample, typically in our clinic. A lot of genetic testing panels are free, depending on what we're looking for. And this is a very convenient thing we do in our clinic. And a lot of patients are very satisfied with how we perform this. The one invasive thing that we offer, and it's not done in our clinic, but done by our surgeons, is what we call a muscle or nerve biopsy. And that is a procedure that's done with our help of our surgeons. It's invasive, but I can tell you that most of my patients do just fine after the procedure, and with very minimal scarring that I've seen and minimal pain. So it's a good thing, and it helps with diagnosis. All right, so this is our neuromuscular clinic. Exciting as it is, we are so grateful for the clinic. I mean, this is how it's grown. And it's more amazing than I could even imagine. There's no way we could get so many people without God's blessings in one day in our clinic. So patients get to see and experience a lot of our colleagues and care providers here. We have our nutritionist, we have our wheelchair vendor, we have our physical therapist, we have our scheduler. This is a lady who's a vendor for one of our products for ALS. We have someone here for she's for respiratory therapy, and we have our genetic counselor and our nurse and our social worker and our occupational therapist and our EMG tech, and of course, our ALS representative, our spiritual counselor, and our speech therapist. Is such a big team, and some of you will recognize our team here today, who are just amazing. We have very specialized clinics, and so we offer that for our patients. So we have a specialized hereditary neuropathy clinic, our acquired neuropathy clinics, which include for CIDP patients, and some of them are combined in the same morning. We have an ALS clinic, we have an SMA clinic, we have an MDA or Muscular Dystrophy Association clinic, which includes like general neuromuscular patients. We have a diabetic neuropathy clinic, as well as a myasthenia gravis clinic. And this is just, we are presenting always our research across the country. So this is one of the posters we created, very simple poster, but interesting in how we discussed here how, a hereditary condition like HNPP can present with back pain. And we saw a few patients with that. So it's interesting, and we do keep trying to push and promote research as much as possible in our clinic. All right, and this is something that's really important, is that in 2 years, with God's blessings, we've been able to really excel and promote our clinic in a way that has just we've got a Center of Excellence from the Hereditary Neuropathy Foundation. Our EMG lab is accredited with exemplary status. We're a partner in care for the Myasthenia Gravis Foundation of America. We're an ALSA affiliated clinic. We're an MDA care center. We got an MDA grant. We have a CMT1A clinical trial, which is exciting and going very well. But the most important award for us, and the most important achievement for all of our team members, is seeing our patients smile and all the satisfaction we can bring to them, and all the improvements and help and therapeutics, including the clinical trials. That just keeps us running. And we're so grateful for our patients, so grateful, of course, for God's blessings and for our amazing, amazing team. There's no way any of this could have been achieved without them. And this is our clinic number and our email address in case anyone needs to contact us for whatever reason. All right. Thank you.